Okay, I think we'll get started. First of all, ladies and gentlemen, this is Dave Mendiola. I'm the county manager here in Humboldt County. And I wanted to just start off this by making a couple of comments, but first a little housekeeping, if you will. And just to remind everybody that if you're coming in on your computer and or your phone, one thing I would ask you is to mute yourself. I do have the ability to mute you, but when we get a lot of people like we have in tonight, and if somebody's had a lot of noise in the background, it takes me a bit to find, because I can tell who it is just because you light up. But in any case, what I want everybody to do is to just go on to mute, make sure you're on mute, and with your phone, it's *6. So if you're coming in on your phone, it's always *6. If you're on your computer, of course, the icon at the top of the page is the microphone. So also, if you do have a camera, we'd love to see you. So if you want to get in that way, that's fine, but you don't have to. And also, I want to remind you too that when we do get to the questions and answer period, which will be pretty quickly, there's two ways you can get in. One thing I will do is I will start and ask for any questions. And if you want to raise your hand, you can do that. Again, that's an icon at the top of the page. It is a hand, and that will alert me that you want to ask a question, and I'll watch those and bring you in. The other way, of course, is to simply unmute your phone. But I think what we're going to do tonight is I'll take about 5 from the hand raisers. Then I'll take then I'll actually ask anybody who wants to come in by phone to do that. So we'll kind of do it in an orderly fashion. And then also, of course, you can come in through the chat, which again, at the top of the page, there's a little square with a kind of a little dip to the right there where you want to make a comment. You can go in there and type in your question as well. I also have a set of questions just in case we run out of them or we haven't covered a particular topic. And so I'll may throw a few of those in as well. But anyway, so this idea came about because of the Humboldt Board of Health, the Humboldt County Board of Health, which Dr. Stringham is the chairman of that organization. And we've been meeting pretty much since mid-April or early April, actually. And and the goal of that health board is obviously to get our arms around this pandemic and to try to find ways to alert our public as to what we know about it, what the current status is of that, and then also, what we can do about it and what we think. Now, again, I personally don't think there's any, a cure for this other than potentially the vaccine long term, but there are some things that we can do. And I think that's what we're here to talk about. And I know there's a lot of questions, a lot of misinformation out there. So that's the goal tonight. And what we're going to do is we're going to start with Dr. Stringham giving us a quick overview about what he's going to do tonight and what the status is and where we're going. And then we'll open it up to questions as soon as he's done with that. So, Dr. Stringham, I'm turning it over to you.
Excellent. Thank you, Dave. So thank you, everybody, for joining us this evening. I'm very excited about this program. And the thing I'm most excited about is that literally the citizens of Humboldt County, each of you, get to design the program. And we have absolutely no specific topics that we want to talk about. And the reason is because most of us on the health board really feel that the amount of information that people are getting is just voluminous. And in a lot of cases, the information is very confusing and can send double messages and lots of other issues. And the other issue, of course, is that a lot of people are feeling like they're not really getting the answers to the questions that they want. So my hope in presenting this evening and answering your questions is that we can get better engagement from people through better understanding. And I think in the end, to me, the best way to engage people, to make sure that every one of us is doing the right things, is to make sure that if there are questions or things that aren't clear, that we can get those questions cleared up for people. So again, we have absolutely nothing on the agenda this evening other than your questions. And I'm really excited about what happens. So I'd like to remind everybody that we know that this is a pretty emotionally charged issue. And so I'm happy to answer any questions, but please try to keep everything kind and understand that we're not really in charge of the virus. We're just in charge of our responses. And we're hoping that everybody can understand that and ask great questions that hopefully will enhance your ability to engage and to do the right things. And so, Dave, with that, I think we're ready to answer some questions if you're ready too.
Very good. Thank you, Dr. Stringham. So what we want to do here is just open it up. At this point in time, I do not have anything in the chat. I do not. Let me just double check to see if I have anybody's hand is raised so far. There's nothing there, but is there a question somebody would like to answer? And just, again, unmute yourself by phone, *6, or if you're on your computer, just obviously you know how to come in and out of that. So are there any questions right now from anybody at all? So just open it up.
Mr. Mendiola, I do have one question. This is Louis Trout, an incoming member to the Humboldt County Hospital District Board of Trustees. I've been contacted by a number of constituents with concerns about the distribution of the vaccine to Tier 1 people. I've been told that the Sheriff's Office has a number of people who would qualify for Tier 1 who have chosen to decline a vaccine. And yet at the same time, it seems the Beehive, the workers at Genesis Home Health, American Home Companion, the RSVP, and Tingley have been overlooked in the planning for the distribution of the vaccine. Is there any plan to try and identify qualified people, especially in Tier 1, who would be able to step up should there be people who decline ahead of them in order to receive the vaccine?
Yes. Thank you very much for your question. In fact, this is a very difficult question to answer. The entire distribution system of our vaccinations here in the United States has been kind of gone through by the federal government at the federal level, of course, also our state government, and to a certain extent by the county. And so there are a lot of different hands that have all kind of helped to shape this doctrine. We also have the ability to kind of look around the world and look at what other countries are doing. And so England, for example, has defined as being Tier 1 from the very beginning, elderly people, nursing home residents, long-term care folks. And in the United States, we've actually changed iterations. And so in the initial iteration, these folks were in Tier 3, which a lot of us didn't agree with. And at this point, they're solidly in Tier 1. And so Tier 1 is going to include mostly medical workers, first responders, people who have very high accelerated risks of being exposed to the virus. But then also we're expanding that so that people who are at highest risk of passing away if they get the virus, and rightfully so, have been reassigned to Tier 1. Most of us are very happy about this, and I think it's a great change. Interestingly, the English had this from the very beginning in the United Kingdom, and the United States has kind of changed our program just a little bit, and again, thankfully so. And there won't be anybody who will be overlooked, and I think in the end, we'll make sure that everybody who needs to be vaccinated will be. There was an initial request placed by our emergency management folks at the Humboldt County Sheriff's Office, and that originally was for 758 individual doses. And the problem has been that the doses, of course, are in short order, and it seems that we'll be getting 240 with this initial packaging, but more will come very quickly. And in terms of what to do with people or vaccinations that aren't claimed, we already know that there will be some people within the ranks of Tier 1 and probably Tier 2 also who won't want to get the vaccination, who may be frightened by it. And so as a result, they may not take the vaccination. And we do have an ongoing list of people who could be used as substitutes. And so there's a collection that we're doing, and this is being officiated also through emergency management. So a lot of this is a plan in evolution at this point. So a lot of us are kind of working on plans. We're very malleable, and we're open to various changes that may need to be made in real time.
Dr. Stringham, Dave Mendiola here again. I wanted to follow up on that. Also, there was information regarding the rollout of the vaccination, that the vaccination itself, because of the elements of freezing the vaccine, there is a very tight window by which we have to get it on the ground and get those vaccinations completed. Could you talk to that a little bit too?
Yes, the vaccination is very touchy. It's a fantastic technology. We're very excited about the mRNA vaccinations. It's the first that we've used of these. But the downside is that they're very fragile vaccinations, and the most critical issue, obviously, it has to be kept at somewhere in the neighborhood of minus 70 degrees centigrade. It's very, very cold, and Humboldt County has obtained the refrigeration devices in order to be able to facilitate that. But the thing that's most critical is that once this vaccination is constituted, so once it is thawed and constituted, there's a very short window of opportunity to be able to give that vaccination to people. They're all individual doses, and so each dose gets its own vial. But the amount of time that we're able to do this, from the time the temperature comes back up, we have 120 hours, which is about 5 days, to give this vaccination, and from the time that it's actually constituted or dissolved into a normal saline, which is the vehicle in which it's given, it's a remarkably short period of time. So from a logistics standpoint, it's kind of a difficult thing for us to do. And so a lot of organization needs to go into this. And that's one of the reasons why we've already anticipated, as you'd asked, whether or not there'd be people who might decline the vaccination and what we would do with those vaccinations. We have a concerted plan to be able to address that.
Mr. Mendiola?
Dave, we can't hear you.
Yes, Dr. Stringham, this is Ken Tipton.
Ken.
Yes, I would like it if you would go through, like you did to the health board a couple of weeks ago, if you would go through the safetiness and how this vaccine has been made. The RNA, it's a little different than flu vaccine. If you would explain that.
Yes, it's a very general question, and so what I'll do is I'll give a kind of a brief summary, and then there are specific issues that people would like to have me address. I'll be very happy to do this. All of us here at the county know that this is a very it's a topic that a lot of us are thinking about, and safety is everybody's number one concern. And I know the constituents, those people in the county, are very worried about how safe this vaccination will be. So first, I want to kind of address the ways that vaccinations are manufactured and how this one is different. And in my opinion, it's actually better. And so in a lot of cases, a virus is administered as what's called an attenuation, which means that the virus is killed and or deactivated. And the virus can no longer infect people. And then we inject individual components or the entire virus in those cases. Now, that is absolutely not what's going to be happening with this mRNA virus vaccination. And the reason I'm so excited about this is because this virus, the COVID-19 virus, SARS-CoV-2, is not going to be injected into people as part of this technology. So instead, what's happening, and we can get into some of the details, but maybe the best way to explain it is that instead of giving an entire virus, what this is really doing is the mRNA is essentially a link. It's a way to describe the manufacture of a certain protein within this virus. So what happens then is mRNA is just a message. It's a message that lets your body know how to produce a specific protein, the S protein, or the spike protein on the surface of this virus. So once again, this is not the actual spike virus. This is not the actual virus at all. This is just an instruction that's given in the form of what's called mRNA. And the best way to explain it is it's almost like taking a computer link and giving it to your body so that your body has the ability to produce a photograph of one very small component of this virus. So there is absolutely no way that that component could ever infect you because it doesn't have the capacity to enter the body because it's just a photograph essentially of a protein. It is not the whole virus at all. So your body gets instructions on how to produce this protein, and then your body produces antibodies to that protein. And by the way, it's not the entire protein, it's a subsegment of the S protein, the spike protein on the surface of the virus. And then in the future, when your body sees that, it launches an attack. And it does that in one of two ways, either number one, and in fact in both ways simultaneously. Number one, it'll assist in your body's ability to make an antibody series to this particular protein, but also in producing T cells that are already educated and know exactly what this virus looks like. So the next time they see it, they kill it, and it happens in a very short order. It's a super exciting technology. I think a lot of people are concerned because this is the very first time we've used mRNA technology as part of a vaccination series. But the best part about it is, even though this mRNA is essentially genetic information, it does not have the capacity to enter your body as a virus. And the other really nice part is this does not have the ability to infect anybody or cause any problems. It does not enter the nucleus of your cells. It does not alter your genetic material. And so far, it seems to be quite safe. Now, I think most people are aware this is brand new, and there have been 44,000 people who've been evaluated as part of Pfizer's group, and 30,000 with Moderna. And so these are large numbers of people who've been through 3 phases of clinical trials. And we've had 3 months of data that have indicated this technology seems actually to be quite safe. So some of the issues that we see with other vaccinations, the Guillain-Barré syndrome and various types of myelitis and neurologic issues, and all kinds of things of that nature, have been seen in no cases in these vaccinations. So they're actually safer than influenza vaccinations as far as we know. And again, it's a new technology, and I think that frightens people. But I think in the end, this is actually a fantastic technology. I'm trying to think of any other issues that would be interesting for people to know with this. There are many different ways that we can impart immunity to people with various types of vaccinations. And about the biggest issue with this particular vaccination is that nobody yet knows how long this vaccination will bestow immunity to its recipient. So what we know is, so in certain cases, is that if a person has been vaccinated against has been given natural immunity to the virus by actually having been infected in the past, that immunity lasts for at least 3 months with most people. And what we're hoping is that the immunity bestowed by the vaccination will be significantly longer. And it certainly appears that it will be, based on what we've seen from these phases of clinical trials so far.
Dr. Stringham, thank you. I want to remind everybody, when you come into the meeting, please mute yourself. We are getting feedback, and I will sometimes mute you. So if all of a sudden you see you're muted, that's because I muted you because we're getting background noise. But in any case, the next question, Dr. Stringham, comes from Deborah Hess. Deborah put her hand up. And Deborah, if you want to jump in here at this time, please do. Please unmute yourself.
Yes, Dr. Stringham. Can you hear me?
I sure can.
Oh, very good. I actually think that you have answered one of my questions, and that is, I believe in
Deborah, we lost you here. Deborah, let me interrupt you, Deborah. Deborah, you're breaking up.
Condition, but now it sounds like I'm class A. Is that right? I apologize.
Yeah, Deborah, you're really breaking up.
I'll try it a different time. Why don't you go on to somebody else?
Okay, Deborah, thank you. Is there Jessica Anderson? Jessica Anderson has a question. If you want to come on, Jessica. Jessica, are you hearing me?
Hi, sorry.
There you go.
Yeah, I was wondering about if we're able to take the vaccine if we're pregnant or nursing. I've heard that we shouldn't, or children shouldn't either, but will it be safe enough later on, or can we take it?
Jessica, thanks for your question. So the trials, even though the trials were quite large, there were a few different groups of people who were fairly conspicuously left out. And two of those groups actually were lactating women and also pregnant women. And so my recommendation for right now is I would definitely check with your obstetrician in the event that you're pregnant and come to a decision about what's best. My personal feeling is that it can't, I can't recommend it because there's really no data on it at this point. And my best guess is that here over the next several months, we'll start to develop a database on this. Either there will be other phases of trials that are done by the manufacturer, or as is often the case, in certain cases, if there's a risk that's felt to outweigh the risk of vaccination, that in certain cases people will go ahead and do that. It wouldn't be my recommendation as a county health officer, but it's a decision that's made ultimately by a physician who's practicing medicine specifically for you. And so that the other group that we're not specifically recommending vaccination be done for are kids under the age of 16. And again, the reason is not because it wouldn't be effective or that it could be dangerous, but that it just has not been studied as yet. And this is not uncommon in clinical trials, that the first iteration of a clinical trial will be people who have the lowest probability of having reactions. And then in the end, we start generalizing our approach out to other people, either particularly young people or people with various other comorbidities, conditions, and things of that sort. But for right now, I would say that I would hold off on vaccinating anybody who's under 16, who's pregnant or lactating.
Dr. Stringham, thank you. I have a question that's come in, and the question is, do the case numbers include retests, including if someone was rapid tested and then PCR tested? That's part two to this as well.
So in terms of case numbers, the case numbers are exactly that, the individual cases. And so, for example, if a person is tested and then retested, it would just be a single individual who underwent those two tests. And as such, we would count that as just one single case. And in other cases, we use the actual number of tests. As you know, with some of there are three criteria by which the state of Nevada defines individual 17 counties as being high-risk counties. And in this respect, the individual tests are all considered in that database. And so the issue is that if we're looking at the number of tests that are done, then all tests that are done count. But if we're looking only at the number of cases, we have approximately 680 cases in Humboldt County so far. For example, those are all individuals. Some of them have been tested multiple times, but that would only count one individual case.
Next, I'd like to open it up if anybody on the phone or on their computer would like to just unmute and come in. Just please announce your name first, please, and then go ahead and ask your question.
Hello, Dr. Stringham.
Hi, who's this?
My name's Brenda Burns. We live way out on Grass Valley, and we have been home quarantining since March. We've groceries, pick up at Walmart, but I've got a husband who's diabetic with high blood pressure and two teenagers that have asthma. So we've been very, very cautious. My question to you is, we've been washing groceries, packages, all these things. Have we decided that getting it from material objects is less of a chance, and so we could possibly quit doing that?
Brenda, that's a great question. My family does exactly the same thing. And what I can tell you is that there are certain ways that we know the virus is spread. We know it's spread through droplet nucleus. When one person breathes in close proximity to another, the virus is absolutely transmitted very efficiently that way, in fact. But what I can tell you is that the virus does survive on surfaces. And under certain circumstances, it can survive for up to about 5 days on certain surfaces. In cold temperature, it survives longer. And on certain substrates, certain types of surfaces, it tends to survive a little bit longer, such as plastics. And so there are a lot of different variables in this. What I can tell you is I'm always in favor of doing things the easiest way. And so what I personally have done is when we shop, we usually bring food into the garage and leave it there for about 3 days if it's not perishable. And then after that, we don't wash it. Certain foods are not very easy to wash. Fruits, vegetables, things with various complex shapes, geometries, things of that nature. And then in other cases, something may have to be refrigerated, and we'll usually wipe that down with Lysol or a similar product. Soap works absolutely fine. And by the way, this is probably a great time to indicate that viruses can either be encompassed with one of two different systems. There's a capsule and there's an envelope. And capsules are very hardy, envelopes are not. And so this virus, thankfully, is in an envelope. And so it's pretty easy to break it up. Soap will do that just fine. Alcohol does. Lysol, lots of other products. Anything that's at least 70% isopropyl or similar types of alcohol is very effective. So I do recommend that you at least wipe things down. And I think it's critical to do that. I know that there are a lot of other health officials who are recommending that we no longer do those things. I think that it matters to me how safe a person wants to be, and especially with folks with diabetes, hypertension, and asthma in your home, and especially because it sounds like you've done a great job of quarantining and hunkering down, staying home, and doing the right things. And to me, it would just be an absolute shame. You've already demonstrated that you're willing to do the right things, which is fantastic. You're part of the solution. So my recommendation would be to just go that extra mile and wipe your things down, be nice and safe, and I absolutely do recommend that. Yes, I do.
Okay. One more question, if I could.
Sure.
On the masks that have the exhaust valves, I know a lot of people went out and bought them. We did. We also have other masks as well. But if you could filter over the valve, would that make them acceptable then?
You know, masks in general are one of the least well understood items of this pandemic, the tools that we're using. And my recommendation is that if you have an exhaust valve on the mask, then it's really giving the wearer better protection than it's giving those around the wearer. And ideally, we should protect everybody, ourselves and the people around us. But your question really is, if you put an extra mask or an extra filter over that exhaust valve, would that assist you? And you know, the answer is that the exhaust valve is there primarily to make it easier to breathe out, so that a person doesn't tire in their respiratory efforts. And but then the issue would be that the entire mask is rendered essentially ineffective. And if you wear a mask over the top of that, because there's an exhaust valve in the underlying mask, then my recommendation would be to just wear a mask over a mask directly against your skin, and not use the one with the exhaust valve at all. So they just don't work very well. And the reason that they exist is because in a lot of cases, those masks are intended for people who either have respiratory difficulties, or they're really dust masks, or masks that would be designed to protect a person, the wearer, from environmental issues, rather than giving the people around us any true protection. So I definitely don't recommend them, even if you take the trouble to put a filter over the top of them.
Okay, thank you.
Thank you for your question.
Brenda, thank you very much. Appreciate it. Is anybody else like to unmute yourself and ask a question? Just please do so. We'll take you as you come in.
Yes, this is Sharon Fitzpatrick. I have kind of a two-part question about the vaccine. The first part would be you had commented that, you know, we don't know how long this is going to be affected, the actual injection. will it be 3 months, 6 months, a year? The first part of the question would be, is there a way to make that determination down the line? And if it's deemed not effective for that individual, can you be revaccinated once you've already been through a course of the vaccination?
That's a good question too. What I can tell you is that there's kind of a joke within medicine that when we start giving people a medicine, that is essentially a fourth phase of clinical trials, but there's a lot of truth in it. And so as this medicine, as this vaccination is coming to market, there are a lot of questions that we still have. And that is absolutely one of them. The duration, how long will this be good for? Given the fact that after the first of the series of two, a person has about 50% of the immunity that they eventually get, and then about 95% effectiveness after that second shot. And so what I think is it stands to reason that if there were to be a booster in the future, and this, of course, is pure speculation because we haven't had the opportunity, that medicine hasn't been around long enough to test this. But my best guess is that in the future, what will wind up happening is we will just have a third dose of this medicine that may be given at 3 months or 4 or 6 months in order to rebolster, to booster that initial vaccination. I think that's likely to be what happens. So it'll be interesting to see.
All right, thank you.
You said there was a two-part question too. Is there another part?
Well, that was it. How are we going to know if it isn't working, and can we be vaccinated?
Okay. Thank you.
Anybody else like to jump in? Please do so.
Yes, Deborah Hess here again. Is it easier to hear me now?
Yes, Deborah, you're good.
Very good. So I have two questions for you, Doctor. The first is I was exposed on the 3rd of December. The person that I was exposed from actually received their confirmation yesterday. So I obviously would like to be tested. I understand from friends who have been tested that when you go to the Humboldt General, there's actually 2 lines that you go in. One is for asymptomatic and one is for people that are experiencing symptoms. I have mild symptoms, but I do have symptoms. Which would you recommend for me?
Deborah, my answer to you would be that even mild symptoms are considered symptoms. One of the things that I wish that everybody realized is that some of the symptoms that people get with this virus are extraordinarily mild. So my recommendation would be any symptoms at all, even a tickle in the throat or a mild headache or a possible fever or maybe chills, not really sure whether you've got them or not, definitely consider all of those to be real symptoms and take them seriously. So I would definitely go in and be tested. And I'm a little bit concerned that your friend had that the exposure was on the 3rd and that confirmation wasn't until the 13th. I can tell you that in most cases, Humboldt General is just doing a fantastic job getting test results back very quickly. And all of us have worked at the county level and also at the Humboldt General Hospital level in order to make sure that people are able to get test results back in a fast fashion so that they can make the right decisions. So hopefully your friend was quarantining and doing the right things, and I applaud you for being tested. The other thing I can tell you is while you're waiting to be tested for tomorrow, I would go into quarantine in any case starting immediately as soon as a person sees symptoms. And the reason is because we routinely put people into quarantine when they're tested if they have symptoms. But my personal recommendation, and this is the case for everybody who's listening, if you think you might have symptoms, if you're not really sure, if you know you're going to be tested, then absolutely start the quarantine immediately so that nobody else is exposed. But Deborah, does that answer your question? Do you have any other parts to your question?
It does, and I agree. I have not been outside my bubble since my friend was tested. because we suspected that they were going to come back as positive. So the second part of my question is, when am I able, when will we know that we can come to Humboldt General for the vaccination? And if I heard you correctly, I originally thought that I was going to be in Class C because I am greater than the age of 65. However, did I understand that you said that we were now in Class A?
No, in fact, that's first. I wanted to applaud you for doing the right things before you even really know that you're positive. I wish everybody did what you're doing, and that is to assume that you're positive, to make the right maneuvers, and to do the things that you need to do. I really appreciate what you did. That's great. So the second is that the various tiers. There are a total of 4 tiers, and tiers 1 through 4. Tier 1 and 2 are what are being handled right now by the Humboldt County Sheriff's Office as part of our emergency management system. And Captain Wilkin is working on this tirelessly. He's sifting through a lot of information that's changing on almost a daily basis and doing a great job of keeping up with things, keeping the rest of us abreast of what's going on. So originally, the issue is that originally Tier 3 was going to be people who, in part, were nursing home residents and long-term care residents. And at this point, we've changed that, and that's changed here in the state of Nevada, and now will include, those people will be included, nursing home residents, long-term care facility residents will be included in Tier 1. And but for people over the age of 65 who are members of the community but are not in a long-term care facility, they will occur after these first 2 tiers, and Tier 1 and Tier 2. So, and the specifics of that likely will occur. Tier 1 and Tier 2 are being handled through our emergency management system, and so that's all being officiated by the county and the sheriff's office. But Tiers 3 and 4 are going to be taken care of probably by private pharmacies, and the distribution of those vaccinations will occur a little bit later. We don't know exactly when, but it'll occur here over the next probably 30 to 60 days, we're hoping. And that will occur rather than being given by public officials, likely will be given at pharmacies that are designated by various governments, local, state, and also federal.
Okay, well, thank you for your answer. So it sounds like that if I am lucky enough to have dodged the bullet, that it will be about 60 days before I can expect the vaccine.
That would be a reasonable guess. And we definitely stay tuned. If tonight's broadcast is successful and well received by the community, we'll likely be doing this again in the future, and hopefully you'll be able to come back and we can give you some more definitive answers. A lot of this is evolving as time is going by, and so we should have better answers in terms of exactly when that'll happen soon. And again, I can't thank you enough for assuming that you're positive and for quarantining before you even get tested. I just, for everybody else listening, this is an exemplary behavior, and I wish everybody did this. This is fantastic.
Thank you, Deborah.
Thank you, Doctor.
Appreciate it. We do have Captain Wilkin is on the line, Dr. Stringham, since we are talking about the vaccination and the rollout. I don't know if you want him to weigh in a little bit about the process.
You know, that would be fantastic. Captain Wilkin is very knowledgeable about this. And if there's some things, Sean, that you'd like to share, I think that would be fantastic. We'd appreciate that very much.
Hi, this is Kathy Cunningham, and I have a question for you. I just found out that I was exposed by somebody who took the test and didn't even tell our work that he took the test, and he's turned out positive.
Mm-hmm.
And I wanted to take the test, but I've been busy over the weekend and haven't had a chance. I was told by some people that I should wait till like the fourth or fifth day to take the test because that's when it like gets into your system to like starting to be able to show if you're going to have it or not. But
Mhm.
other people say wait longer, and I didn't know which would be better to do, if I should do it right away or if I should wait. And I've been in quarantine. I've not gone any. The only place I've gone is outside to feed my animals.
Yeah, Kathy, I know of the case, and I was really sorry to hear about this. And I think that in general, we really appreciate the fact that you're quarantining. And the question is a great one. What I'd like to be able to do is not only answer it, but kind of expand on it a little bit, because I think a lot of people have this question. So the first issue is that when we do medical testing, any medical testing, testing for COVID-19 or even other things, what we're doing really is testing in order to figure out what to do next. And so in this case, what I can tell you is that the CDC originally, as of about 2 months ago, recommended that we not even test people in your position. That if a person was exposed and if they were having symptoms or not having symptoms, that we knew that they were going to go into quarantine. And so we did not test those people. Now, here in Humboldt County, we never agreed with that philosophy. From the very beginning, when the CDC made that recommendation about 2 months ago, we realized that it was somewhat short-sighted, and we wanted to be able to continue the approach that we used. So we continued to test people who were contacts, even though the CDC was recommending against this. Now, the reason was because if a person who was in contact, such as you, was positive, then there presumably would be other people who we'd want to quarantine who you've had subsequent contact with, and that's the reason. But then the question is, at what point are you capable of generating a positive test? Because the issue is that if a person is infected, and let's say that that's day zero, that a person comes in contact with a person who has this virus on day zero, usually for most people, they're not going to develop symptoms until about day 5. 5.1 days is the average duration that elapses between the time you're exposed and the time that you actually develop symptoms. But the question is, how long does it take you to actually be able to create a positive test when we test you? And the answer is everybody's a little bit different. Most people aren't going to show a positive test until about day 3. And in some cases, it may take 5 days before a person can manifest that test. In general, by the time you have symptoms, you probably will be able to have a positive test. And so the reason that you've come up with a figure of 4 to 5 days, we actually use that figure very frequently. And the reason is because we like to give people a little bit of an opportunity to be able to generate a positive test. Because if you're negative at day 1 or day 2, then most of us would say, well, let's test you when you're likely to be positive. So that's why we do it that way. But we already know that you're going to be in quarantine. So from your perspective, it doesn't change anything. And then the other issue is, of course, if your test is negative, do you have to stay in quarantine? And the answer is yes. If the test is negative, you stay in quarantine for 14 days. But if the test is positive, then you only have to stay in quarantine for 10 days beyond the point that you were tested. So it's actually almost from a quarantine duration standpoint, a longer duration quarantine if you are negative and a shorter quarantine duration if you're positive. A lot of people kind of think that's curious, but the reason is it can take up to 14 days to develop this illness after you've been exposed. But nobody, in general, nobody goes on to be infectious after day 10. So if you know somebody's infected, shorter duration quarantine. If you know somebody's negative, then we keep that person in quarantine. So even if you're negative, the quarantine will be 14 days in total. Kathy, do you have other components or other facets to that question?
Not that I can think of. I had somebody tell me that, you know, you could potentially be, if it came up negative, you could be asymptomatic, but could still possibly get it later. And I don't know if that's possible. I mean, there's so many different things I hear. I mean, what's right, what's wrong.
You know, I love the
So,
question. It gives us an opportunity to kind of sift through the details. And for everybody else who's listening, they can learn something too. So the issue is if a person has not had any subsequent exposures, so if the only exposure to a person who had this virus as in your case several days ago, after 14 days of not having had any contact with other people, there really isn't any way that you'd be able to get this. So after 14 days, then the contact that you had with your coworker would be kind of a thing of the past. It isn't really possible after that to become infected. The concern we all have, of course, is future contacts. Could you be in contact with somebody else? And as more and more people in the community develop the illness, it's more likely that people will have multiple contacts with multiple people who are infected. But for this particular contact, at the end of 14 days, there will be no further risk that you could potentially develop this virus from that contact. And we really appreciate your quarantining. This is very nice.
Okay. Yeah, because I had scheduled testing on tomorrow. I shouldn't do it another day or do it tomorrow just to see what it comes up. And then it's 3 to 5 days to find out what happened, what the result is. So I just kind of wasn't sure what to do about that. So thanks.
No, thank you very much. It's great to be able to explain things to people, because my feeling is that I'm hoping that there are lots of people listening. And the reason is because the more people understand the specifics, kind of the hows and whys of what we're doing, I think the better buy-in in general we get. And the more people understand, none of the things that we're doing are being done in secret or, and I'm very happy to explain kind of the logic behind what we do, in hopes that when people understand why we're doing what we're doing, they'll support some of the activities and understand that we're really trying to keep everybody safe. So thanks so much for your question.
Dr. Stringham, next question comes from Patricia Tyndall. And the question is, if you've already had COVID, should you get the vaccine when the opportunity arises? And then there's one more question.
You know, I can go ahead and answer that question first. And that is a really good question. And Patricia, what I can tell you is that I've wondered that myself. What I can tell you is that the CDC has given lots of recommendations about vaccinations, and the manufacturers, both Moderna and also BioNTech with Pfizer, have given many, many different recommendations, but that's not one of them. And we don't know the answer to that question at this point. So what I can tell you off the cuff is that as a county, we have to make a decision without really getting recommendations specifically from CDC or the manufacturers, because this has not been addressed. So I'll tell you what my personal feeling is and what my recommendation for folks in our county is going to be. There are two different types of immunities that you can get. One is natural immunity, which is when a person is infected, and then in the shadow of that infection, that person will have naturally manufactured antibodies and T cells. Well, the problem is the antibodies only last for so long. And then after that, those antibodies aren't present in large enough quantity to be able to mount a fight fast enough to be able to make a difference for the infection. The T cell immunity is different. So those T cells do last longer. And but the issue is that that as time elapses, your ability to fight a second infection goes down as a function of time. And so as a result, my personal recommendation for folks in Humboldt County will be that if you've had this virus naturally, I'm still going to recommend that those people have the vaccination in addition. So to say that again, if you've had natural infection, so you theoretically have natural immunity, I'm going to recommend that those people be vaccinated anyway. And the reason is because we think the vaccination will give immunity longer. So we're not sure exactly how long it's going to be, but we think that it likely will be better and more long-lasting immunity. So yes, we're making the recommendation that people be vaccinated anyway. What's the second part of your question?
So the second part of the question is, how does one get on, in quotations, the list through the county for the vaccination?
You know, this is a decision that's kind of being made in real time at this point. The health board discussed this for the first time on Thursday, and we're still kind of in the process. Captain Wilkin and I are working on a way to be able to get a list together. And ideally, what we'd like to be able to do is offer vaccinations to Tier 1 to other tier 1 people, because remember that the number of vaccinations we're getting in during this first shipment will be less than the total number of people who qualify as tier 1 in our county. And so what we're hoping is that the list can incorporate people who are at highest risk for developing this virus. And but if a person is theoretically interested in being on that list, then please, what I'd like you to do is send an email to the county email address, the COVID-19 email address, so that we can know who you are, and we can potentially add names. And again, the list is still kind of in the thought process at this point. A lot of these decisions are being made in real time, and there's not a kind of a formal concerted plan at this point. We're still kind of figuring out how to do that. But if you're interested in being on the list, please email us so that we've got a record, and we will respond to you.
Dr. Stringham, we do have Jeanette Black, who's got her hand raised. Jeanette, if you want to unmute yourself, come on in and ask your question.
Hi, thank you. I have a question about allergies. If you have allergies, should you get the vaccine, or are there any specific allergies that should preclude you from getting the vaccine?
I like that question because of all of the contraindications. And a contraindication is kind of a fancy term that means reasons for which a certain treatment should not be given. And so the contraindications for the Pfizer vaccination include allergies. And they were very nebulous, not very detailed in exactly how they went about explaining that. And so my recommendation would be that, to me, an allergy that would mean that I would not recommend having this vaccination would be a history of serious allergy. Sometimes anaphylactic reactions are kind of the granddaddy of allergic reactions. They're life-threatening, systemic, depressed blood pressure, respiratory compromise, very, very serious allergies. And so if a person certainly has had a history of anaphylactic reactions, I would absolutely not recommend that they have the vaccination, just blanketly. If a person has had severe food allergies, has had to use an EpiPen or similar device, or carries an EpiPen, or has an allergist that they see for symptoms more severe than just mild seasonal allergies, then I would not recommend that that person have the vaccination. And when it comes time to actually receive the vaccination, so Jeanette, when you are a candidate for the vaccination, if you have allergies, then my recommendation would be to consult with your doctor. And if you're not a tier 1 or tier 2 person, then you'll likely get a little bit of time to be able to make a decision. Number one, there'll be many, many more people who have this vaccination during the early stages of administration to the general public. And so there'll be a lot more that's known about this. We may subsequently determine that if a person has allergies to nuts or strawberries or eggs or various other things, that it would preclude them from getting this vaccination. So I think we'll know a lot more about this. Interestingly, because the vaccination is so clean, it's not grown as some of the influenza vaccinations are. There are very few things that are in this vaccination, but there's always the concern that a person could have a history of very vigorous allergies, and those would be reasons to not have this. So, does that answer your question?
Yes, thank you.
Thank you for calling.
Dr. Stringham, next question comes from Patricia Tyndall. And it's the question is, if you have not had COVID, but get the vaccine, can you still be a carrier to others, or can you throw away your masks?
Patricia asks really good questions. She's frequently at our health board meetings, and I don't think I've heard a bad question from Patricia. That is also a really good question. And the best answer I can give you is we don't know. There is speculation, and there has been speculation for quite some time, that if a person gets this vaccination, that they may be capable of transmitting the virus if they get it while they don't get sick. And that is purely theoretical. We do not know if that really happens. Just in getting to know the virus over the last 9 months and kind of being introduced to what it can and can't do and kind of how it works, My best guess is that that's not going to happen. And my best guess is that if a person has been vaccinated and then goes on to actually be exposed to the virus, I think it's very likely that they will have very small quantities of this virus. But the whole point of being vaccinated is that viral replication, that virus's ability to multiply within your body, goes down a lot. And so my supposition, I'm speculating because we really don't know the answer to the question. So in speculation, I would say that it's likely that the number of viral particles that that person would shed would be very small indeed. So the second part of the question is, should I still wear a mask or can I throw those away? And the answer is this. Even if you're going to be very careful driving, we still have to wear a seatbelt. So safety strategies always involve multiple layers. And in the end, the most important part of any safety strategy is to make sure that even though one layer of that strategy is particularly good, that we still in place those other layers so that if there's any type of a problem that we're still okay. So I still recommend, even after people are vaccinated, that they wear masks. Will we always have to wear masks? No. Once enough people have been vaccinated, once the number of viral cases drops, we truly at some point will be able to take our masks off and remember all of the months that everybody had to wear masks, and this will just be a bad memory, and there won't be any additional masks in the future. I don't know exactly when that's going to happen, and so for now, definitely keep those masks on.
Thank you, Dr. Stringham. We're going to stick with Patricia. Is there a cost to the vaccine if you are on the list?
That's a good question. So the federal government had agreed to pay $1.95 billion for a total of 100 million vaccinations, which was going to be enough to vaccinate 50 million people. And so those are what the numbers look like. If you do the math, the federal government is paying $19.50 per vaccination. And so my understanding is that for the first 50 million people who are vaccinated, I do not think there is a cost to the individual. And a lot of this stuff is, a lot of the information that's coming from the federal government is evolving as a function of time. And so, but according to what I've read and what I've heard, what I've seen, it appears that this vaccination will be provided at no cost to citizens, at least for that first total of 50 million people who were vaccinated. After that, to be honest, I'm not sure exactly what's going to happen, but what I can tell you is even in the future, if people did have to either pay for boosters or for vaccinations in the future, the prices are very, very reasonable. They really are. You can get a vaccination. The actual price of the vaccination is about the same price as a couple of N95 masks in a box, and probably a lot more convenient to use too.
Dr. Stringham,
Hey,
so
Dave,
next question. Oh, go ahead. I'm sorry. If somebody wants to get in here.
Yeah, this is Dennis Werner, Dave. How you doing, Chet?
Good.
Hey, it's good. How are you doing?
Good. So my question, I have a two-part question. From the very beginning, your recommendations and from you and members of the medical community have been mostly about wear a mask, social distance, and wash your hands, which is 100% focused on exposure, limiting exposure, correct? So my question is that, we know that it's not only exposure that causes us to get sick from a virus or any other viruses as far as that goes. So a lot of it depends on your body's natural resistance or immunity. And there are things that we can do to improve that. And so things like exercise or sunshine, getting enough sleep, reducing your stress, vitamin D, vitamin C, supplementation. And those are not anecdotal things. The literature is replete with evidence of effectiveness of vitamin D against viral infections. So my first question is, why have you not recommended anything to keep ourselves healthy to resist the virus rather than just be not exposed to it? And then my second question is, there are many members in your profession that had experience with treating lots of COVID patients and were getting amazing results using different alternative treatments. That Vladimir Zelenko up in upstate New York, for one, he treated over 500 patients with 100% success. You know, he was using hydroxychloroquine and I think erythromycin and zinc. But the frontline doctors were also getting great results, and many other doctors in their profession as well. So I'm just wondering why those doctors were just shut down and excluded from the conversation, whether it be from social media and just from, you know, you just didn't hear anything about those guys because they were just shut down when they were actually the ones that were in the front lines treating some of these people and getting tremendous success. You know, it seemed like in the past, you know, doctors would get experience with patients and have a successful result with a particular treatment, report it back to the profession, and then, you know, the doctors would investigate it or try it with their patients, and if it was successful, you know, they would use it. So that just doesn't seem to have happened. So can you explain to me why that happens?
Yeah, Dennis, these are fair questions. Of course, you and I have different approaches in medicine. I'm a pretty traditionally trained allopathic physician, and you're a chiropractor, and so we both come at similar problems from slightly different angles. So the first question is predicated on the fact that we haven't made recommendations for bolstering people's immune systems, but in fact we have. And so I think in the end, in my own practice, I tout vitamin D, and it has absolutely been shown in allopathic medical studies that if people start a COVID-19 infection already having a vitamin D deficiency, that they tend to do less well. And so we absolutely do recommend vitamin D2 supplementation for most patients in our practice. And the other issue, I think, is that that really what we've concentrated on. Well, we give D2. So yeah, D2 is a prescription drug, and we give it in 50,000 unit doses. It's better absorbed and more effective than vitamin D3, which is over the counter. But in my own practice, what we do is we absolutely do concentrate on those types of things. At the county level, the primary mission that we've had has been to stop the spread of this virus. And it's true that you can handle this virus at a couple of different levels. From a public health perspective, my approach is a little bit different from my approach in my own private practice. So when a person in this position of county health officer is dealing with largely with a community, we're trying to prevent spread, and that's the primary mission. In a practice or when dealing with individual patients, you're absolutely correct. We do try to do the things for individuals that will bolster immune systems: exercise, weight loss, all psychological health issues, all the other things. But that's really why we've concentrated on primary prevention, and that's really what we've done. The other issue, so the question predicated on the fact that we haven't addressed prevention. I really think we have. And then the hydroxychloroquine, I am familiar. You had sent me some information. I'd read about it, and then you and I talked on the phone, had a very pleasant conversation a number of months ago. So hydroxychloroquine, let's address that. So I really wish that hydroxychloroquine would have worked. We had at one time 29 million doses back in the early phase of the pandemic. It was touted as being kind of a wonder drug, and admittedly, some of the initial studies were really impressive, but it has absolutely been subjected to multiple double-blind studies, and hydroxychloroquine really fell down in those studies. It did not have much of an effect. There's always an assumption that if allopathic physicians don't do something, that it's because we're holstering that or we're sequestering it. We're not bringing that to bear. But the bottom line is that in allopathic medicine, we have to be able to prove that something has an effect. Primarily, that's the number one thing. Have to prove that it works, have to prove how it works, and have to prove that it's safe, those three things. And when hydroxychloroquine was studied, it just didn't have the the power to go. It didn't wind up working very well. And there have been a number of other things that you and I talked about previously during our phone conversation, like the steroid administration. And as it turned out, when you and I first talked about that, it was still very new technology and to give steroids for this type of an infection. But boy, has it worked fantastically. And in fact, some of the things that you talked about during our first conversation a number of months ago, like steroids, are actually one of the primary reasons why death rate with COVID-19 virus has gone from 6% when you and I had that conversation down to about 1.8% now. And that's if you look at the numbers of actual diagnosed cases. But I think you've brought up some interesting points, and we absolutely do subscribe to bolstering immune systems. But as a public health physician, my primary mission is to teach people the things that they need to know in order to prevent primary infection, spreading this virus from one person to another.
Is the treatment like the hydrocortisone, the vitamin C, the vitamin D, and the heparin that we talked about, is that available at ACH?
What I can tell you is that that when people go specifically to the hospital for respiratory failure or various other illnesses that are associated with COVID, the steroids are absolutely a mainstay of therapy at Humboldt General Hospital. I can tell you that Dr. Farr and the other physicians at Humboldt General Hospital really stay on top of the latest data with all kinds of different treatments, convalescent plasma, which also has not worked out to be the treatment that we thought it was, and also positioning, which is a fantastic thing to do, various types of vitamin supplementations, and also steroid administration, absolutely.
Okay.
Dennis, thanks so much for calling in.
Yeah, you bet. Thank you.
Dr. Stringham, so let me go back here. I've got a couple more that have come in. This one from Stephen Fields at KWNA Radio. I keep hearing time and time again that the regular flu has X amount of deaths each year, and the media doesn't make a big deal about that. Even though I am sure Dr. Stringham has covered this many times, could you please have him discuss the comparison of COVID to the flu?
Mm-hmm. Absolutely. I was hoping that somebody would ask that question. And Stephen, if you're listening, I appreciate the question and the opportunity to kind of set things straight as far as that goes. So COVID is like the flu. We hear this a lot. And what I can tell you is it absolutely is nothing like the flu. And I'll tell you why. Most years, approximately between 20 and 60,000 Americans pass away as a result of the flu. Why don't we hear that? Well, it depends on the circles that you run in. In the circles that I run in, yeah, we hear actually that's actually a common thing for us to hear. In a public circle, you probably don't hear that very often, but most physicians are easily able to quote the number of people who pass away or people who are infected by influenza each year. So it's a very, very common illness. But when you look at 50 million people who make it the flu during the course of a year, and last year, for example, there were 34,000 deaths across the United States. So somewhere in the neighborhood of 1 in 1,000 people pass away as a result of the flu. And that's a pretty typical year, 1 in 1,000. That's a small number. If you're one of those 34,000 people, it's not such a small number. But for the population at large, the risk of any particular individual passing away as a result of the flu is quite low. It is. Now let's compare that to COVID. So far we've had almost 17 million cases in the United States. Today we passed 300,000 deaths. And for anybody who wants to get an accurate view of what that looks like, I would say that 60,000 is about the average number in a football stadium. So if you've ever watched a football game live and the stadium's been packed, you've been in the presence of 60,000 human beings. And multiply that by 5. I've never been to a stadium large enough to seat 300,000 people because no stadium of that nature exists as far as I know. But so far we've lost that number. And It's about 3/4 of the number of people who died during World War II. And 70 years later, we're still talking about that one. This is 300,000 human beings. And I want you to stop and think about that. This has been politicized. We've talked about it a lot. It's not that big a deal. 300,000 people. And I can't even really talk about this without getting a little bit choked up. This is nothing like the flu. Nothing like the flu. So the death rate with COVID started at about 6% back in the early months. And at this point, as of today, if you do the math on 7 million people and 300,000 deaths, you'll come up with a death rate of about 1.8%. That's about where we're at right now. And so you compare 1 in 1,000 to almost 2%, 1 in 50. This is nothing like the flu. This is a very serious illness. And for those people who don't go on to pass away, one of the things that frequently we don't talk about, you don't hear this a lot in the news, but there are plenty of long-term illnesses that are happening as a result of this virus. So we have long-term respiratory compromise, which means that a person who used to enjoy hiking through the mountains doesn't do that anymore. They can't breathe well enough to do that. Or a person who used to enjoy playing baseball or playing with their kids, they can't do that anymore either. We're not showing a lot of that on the news, and I don't know why, to be honest, because to me, those are the cases that scare me the most. It's a matter that if a person's young and healthy, for whatever reason, they don't seem to be afraid of this. But I've known remarkably few people who've had long-term illnesses as a result of influenza, the flu. And I've known quite a number at this point who are no longer doing a lot of the things that they used to enjoy doing. We've had almost 700 cases of this in our county so far. And I've had an opportunity to interact with many, many of these people. So this is not like the flu. The other thing I'd like to address while we're talking about this is that a lot of people attempt to drop those percentages by saying, well, you know, there have been more than 17 million people who've had this. It's probably closer to 100 million. We can massage the numbers in order to get those death rates down. But understand when you do that, you're not dealing with actual numbers. You're dealing with made up numbers. Even the CDC thinks that we may have had quite a number more of these cases than we've actually diagnosed. But I don't know that that's accurate. And even if it is, we can't use numbers that we pull out of thin air. We have to use the numbers that have actually been diagnosed. And as of today, the 14th of December, that number is 2% lethal. So yeah, Stephen, thank you very much for your question. And this is not the flu. It is not the flu. I wish it were, but it isn't.
Thank you for addressing that, Dr. Stringham. One other thing that I'd like to iterate is that the media does start running get your flu shots about August.
You know, it's a fantastic thing to do, and I applaud you for bringing that up. What I can tell you is we've had 7 fatalities in our county, and one of those 7 fatalities was a gentleman who had both influenza and also COVID simultaneously. And I can tell you that if you're going to pass away from COVID-19, the most likely thing that will happen is influenza and COVID-19 at the same time. That is about the highest death risk. And what I can tell you is that influenza is very preventable. The vaccination that we give has 4 different iterations of the virus. And my recommendation is for everybody listening, if you haven't yet had an influenza vaccination this year, please do that. Please do that.
Dr. Stringham, I'd like to go now to Nancy Brinkotter. Nancy, go ahead and unmute yourself and ask your question.
Good evening, Dr. Stringham. Thank you very much for doing this and taking my call.
Hi.
I have a 2-part question for you. What about construction workers and wearing masks in the workplace, outside amongst other co-workers, or sometimes they commute together in a truck that has 4 doors and things like that, and the exposure there to them going out and working and then coming back home to us, and just in general working with other employees?
You know, Nancy, if I can, what I'd like to do is kind of take your question and answer it, but also use it as an opportunity to bring something up that we see a lot that I don't know if people really understand this. So as a construction worker, I mean, wearing a mask can sometimes be difficult because they're working very hard and, you know, typically breathing a little bit harder, faster than a lot of people would who have more sedentary type positions. And so my recommendation is that I still recommend that they wear those masks all the time. And if they need to reduce the intensity of their activities in order to accommodate the mask, that's probably the safer way to do things. The other thing I can tell you is what some of the mines are doing, and that is with a four-doored crew cab type configured pickup truck. It's my recommendation that a four-seat vehicle be used only to transport two people and to increase the number of vehicles so that those employees can sit diagonally and maximize the distance between them. N95s are absolutely readily available at this point. In the beginning, they weren't. And so my recommendation is if you have to be in an enclosed environment, first, please make the assumption that every single human being in your environment is infected. In law enforcement, the assumption is that everybody around you has a gun. And I think it's a wonderful assumption in medicine. Certainly in the HIV days, our assumption was that every single patient had HIV, and we would all wear universal precautions always. And so it's just kind of a new way to bring an old thought process to a new illness. So make the assumption that everybody in that truck has this illness, and sit far enough apart from there and from them. N95 masks are a great thing. Slow down the activities so that when you're actually on the job site, that you don't have to take the mask off in order to accommodate breathing. And then I'd like to kind of use your question to kind of launch into another similar related issue. When those construction workers get off work and it's time to go grab a couple of beers and relax, oftentimes they'll take their masks off. And I don't understand why. So there's a concept, I've called it timeout phenomenon, where people just kind of make the assumption that, hey, I was at work a couple of hours ago and I was doing all the things I was doing and I was in an officiated environment and I had to wear a mask, but now it's time to kind of let my hair down. And I guess that's not a good comment in my case, but it let my hair down and have a drink and relax and enjoy myself. And for some reason, that's about the point where this gets infected, where the people get infected. So you have a person who's had great and exemplary behavior in their truck, on the construction site, doing all the right things, and then for whatever reason, they decide to stop doing those things at 5:30 in the afternoon, and that's where most of these infections are occurring. So my recommendation in your case is to encourage your folks to make sure that these people understand that just because they're off the clock doesn't mean that they can't get infected, and they still can't earn a living for those 14 days that they're quarantined, or the 10 days that they're quarantined if they're actually infected, if they get infected while having a couple of beers after work. So it's very important for everybody to be cautious at work and cautious with their coworkers after work. Do you have any other questions as far as that goes?
I appreciate that answer, and that covered it. I do have a question about if it doesn't seem like it's coming from the top, from the company, that you should wear a mask, or they're practicing, and just how do they have the gumption to say, this is what I'm doing for my family, against all of their coworkers. And a lot of men in this particular instance just think they're not going to have it, or some of them have had it, but they come into the office at night and they don't tell anybody. And then the workers don't know, and they happen to go into the office. And so would you recommend wearing gloves or sanitizing or those type of things?
You know, I think gloves are a great idea, but if a person chooses to wear gloves, and I generally don't in my private life. Here in the office, of course, I do, but I'm a regular hand sanitizer. So and if you're always sanitizing your hands, then the gloves are probably less significant. I see a lot of people put gloves on at the beginning of the day and then take them off at night, and that almost, in fact, it doesn't almost, it absolutely unabridgedly it sacrifices the entire advantage of having those gloves. The power of gloves is when they come off. So when you take a pair of gloves off, that's when the gloves are giving you the power that they have. Your hands underneath are sterile, and as long as they're sterile when the gloves go on, then when you take those gloves off, then your hands are sterile again. Essentially, one pair of gloves functions the same way as a single hand sanitization does. And that's the reason that I don't generally wear them, because if I wash my hands with a hand sanitizer, then that's about the equivalent of having worn gloves and then taking them off.
Okay, thank you. And I heard a short tail part of if you're under 16, you're not recommending the vaccinations. I haven't heard anything about that. I just heard that little bit, and I want to thank you for your time tonight.
Thank you very much. Yeah, the vaccination is likely will be given to people under the age of 16 in the future. It's just that the third phase of clinical trials from both of the companies that are manufacturing the mRNA vaccination did not specifically address people under 16 years of age. So for right now, it's true. It is our recommendation that they not be vaccinated. But stay tuned, because I think that in the future, when more is known, we likely will start making the recommendation, but just not now. So, Nancy, thanks so much for your question and for helping us out in the community.
Thank you.
Dr. Stringham, next question comes from Preston Grieve. And the question is, once you have tested negative for COVID, is there a reason to do a follow-up test after it? If so, in how many days?
Excellent. Preston, I hope you're doing well. And for those of you who don't know, Sergeant Greaves is with Humboldt County Sheriff's Office, a great guy, really like him quite a lot. So Preston, the situation is, the reason there's confusion about this is because there have been multiple recommendations that are made. We had a total of 3 different sets of recommendations with retesting after a person is infected. So in the early days, we weren't testing people because we didn't have enough tests to go around. And then sometime about 60 days into the pandemic, we started testing people and started to find, much to our chagrin, that people were remaining positive for a lot longer than we thought they were. And then subsequently, we stopped testing, and that's the most recent iteration. So we no longer test. Here's the reason why. Because the assumption was, when we were testing people initially, that that if somebody was positive, if they were still positive on retesting, that they were no longer, that they were not eligible to be released from quarantine. Well, the problem is that it doesn't take much to light up a positive test. In the case of the nasal PCR tests, you're testing for one of 3 different genes that are associated with this virus. And so when these individual viral particles die off, they're no longer infectious, they're incomplete, they don't include an envelope, they don't have the ability to, they usually don't have spike proteins, they're just individual strands of RNA that are floating around in your nasal passages. It takes a long time to get those cleared out, but you're no longer infectious. So the problem was, when we tested people, when we required negative tests to release people back to work, what was happening is we were finding that a lot of people still had evidence of an infection, even though it took us a few months to realize these people were no longer infectious. So at this point, what we realized is that if you were tested 10 or greater days ago, you are no longer infectious, as long as you have a competent immune system and your immune system is capable of fighting this off. So you have to have no symptoms, which means no fevers, no cough, and that has to all be gone for a total of 24 hours. And you have to have been in quarantine for a total of 10 days. But once that's the case, we do not retest people. Why is this confusing? Well, number one, because there are 3 different renditions of this that we've used over time. But the second, and maybe the more important reason, is some employers are still requiring that in order for people to go back to work, they have to have 2 negative tests. We're doing our very best to educate those employers. We just dealt with a case a couple of days ago where an employee was ready to go back to work. The employer would not accept them back to work because they did not yet have their 2 negative tests. And now, after this explanation, I hope everybody will realize that negative tests, negative retests, have no usefulness. There's no utility, no reason to do those things. We had an employee at a local employer in the very beginning who continued to show positive tests for 8 weeks. And back in those days, we kept her in quarantine for 8 weeks. That wouldn't happen anymore because we've learned more about the virus, and we now know that retesting is not a useful thing. So I know Sergeant Greaves is not on the phone, but hopefully that answers his question.
Thank you.
Ah, you are on the phone.
Thank you, Dr. Stringham.
Thanks.
Thanks, Preston. So I have nobody in the chat room, and nobody's raised their hand. Wait a minute. I do have one in the chat room. And this is from just last name, I'm assuming, Cooney. Once a business has been exposed, what is the recommendation?
So once a person's been exposed, our recommendation is that person immediately contact us. And so my recommendation is once a person's been exposed, there are a couple of different mainstays or general strategies that we like to use. So the first is that once a person's been exposed, we want that person to be tested. And the reason is we want to be able to know whether or not that person is infectious to other people. And if so, who else we may need to quarantine. Because the issue is that we know that person who's been exposed is going to go into quarantine. And assuming they don't actually develop the virus, they're quarantined for a total of 14 days. But of course, the next thing we need to know is whether or not that person is infectious, because if they are, we need to go back and start looking at their subsequent contacts. And that's the reason it's so critical. So there are two different things that a person would do. The first is they'd be tested, and then the second is that they would go into quarantine for those 14 days. So if you know you've been exposed, if you've heard through the grapevine that somebody's been exposed, then my recommendation is reach out to the FAST team. In most cases, people find out that they were exposed by members of the FAST team. So our contact tracing unit that makes telephone calls and usually advises people, hey, you've been exposed and here's what we recommend you do. But every once in a while, a person will find out faster than the FAST team is able to contact them. And in those cases, my recommendation would be to reach out to the county at the COVID-19 website, or email address that we have, and maybe we can show that here on a screen at some point so that everybody's able to see that. And please make contact. Ask that a member of the FAST team contact you. You don't have to explain why or anything of that nature. It's confidential information. But if you could just give an email to the county and say, will you please have a member of the FAST team contact me? I have some information that would be of use to them. And so that would be one way. The second way that you can do it is you can always just go directly to the testing clinic, the West Campus Clinic. Be sure to call the hospital first to receive instructions on exactly how they want you to do that. And so it's very important that people not just go to the hospital, because the West Campus Clinic is actually where we're receiving people who may be infected. So you can do that in lieu of contacting the county, because at some point you're going to be tested anyway. And so my recommendation would be to potentially be tested fairly quickly at the West Campus Clinic. Any other questions?
Dr. Stringham,
Yes.
let me clarify that last question. I think what she was asking was, once a business has been exposed, so an employee finds out they're positive and they've been at work, maybe something like that, what is the recommendation to that business?
Usually what happens in a case like that is the FAST team becomes aware that an individual there at that business, we just had a case of this nature recently. And so the FAST team will receive information that a person has been infected at that place of employment. And at that point, usually the FAST team makes contact with the employer and gains some information. We initially make contact with the employee, the person who's actually infected, and then we get additional information about schedules and who else may have been involved and things of that nature. And a lot of that information comes directly from the employee. And then when we call other people, we make a decision about what needs to be done with that business. We've had a number of different businesses that have had people who've been infected there at the business. And but one of the things that I'm very proud of, and I think our county, I think our businesses have reason to be extraordinarily proud of this. The number of cases that have been transmitted in Humboldt County businesses is remarkably small. That number may be zero, and but at most, it would be a handful of people of the almost 700 cases we've had so far. The vast majority of these cases are transmitted outside of businesses and in private environments instead. So our county's businesses are doing a fantastic job in containing these viruses, in following procedures. I know we hear a lot of complaints about walking into such and such a business and seeing people not wearing masks and not doing the right things. But what I can tell you is that has not translated to any significant number of infections. So that's the way that we handle people who've been exposed or potentially contacted at a business.
Thank you, Dr. Stringham. I want to project this for everybody. This is the email address. I believe they can see that now. If you want to copy that down, COVID-19, COVID-19 at HumboldtCountyNV.gov. So there's if you want to take time to take a few moments to copy that down, pretty straightforward, COVID-19 at HumboldtCountyNV.gov. Okay, so anybody else have any questions? I have nobody in the chat room right now, so if you've got a question, go ahead and jump in. Okay, Dr. Stringham, looks like we've come the end of this first edition of your meeting. I know we were talking about doing this some more in the future if it was helpful. I think we had a total of about 72 at one point in time. And the one thing I would recommend to anybody listening here today would be to, if you've taken this information, we're going to put this on our website. It'll be available at the county website, which is www.hcnv.us. That's the official county website. And when you get on there, you will see there's a COVID-19. You can click on that at the very top. That'll give you updates on pretty much everything COVID over the last 9 months. And you'll also be able to see all the recordings from the health board. So that's that'll be there at that time. Also KWNA, and I believe 90. See, I'm trying to remember the other one. Well, I think he's doing on 94.3. Jace over there is was going to simulcast. They're going to re-record that a little later on. So anyway, so we are at the end of this. I want to thank you, Dr. Stringham. I want to thank everybody for joining in tonight and jumping on the call and asking questions and listening in. We really appreciate it. It's been a long haul, folks, and I know we're all sick of it. But I think with the vaccine on the way, the very best thing I think that we can do is to, just continue to do the things that we know can keep us away. I think one of the questions tonight that kind of stood out to me was about the construction workers and what can they do even if their the management team is not demanding. I think you said early on, Dr. Stringham, the one thing we can do is we can't really control other people. And none of us want to be told what to do, but what we can do is protect ourselves. Mm-hmm. And by wearing masks and the distancing, if you're worried about it, wear your mask, distance, and wash your hands all the time. And, even with family or friends, and you're not sure, just keep your distance and things like that, and just be cautious until which time we can get down the road where a lot of vaccinations have been out and we have a chance to do something. I did get one other text here. Captain Sean Wilkin was on the line, or I thought he was, and I called out to him, but he wasn't there. I don't know, Sean, if you would like to jump in and just give us a quick overview, if you don't mind, on the vaccination rollout. We've talked, there was quite a few questions on that front. And I just didn't know if there was something that we missed or any gap that you might want to fill in.
Yeah, Dave, can you hear me?
Yes, sir.
Okay, so I know we're getting to the end of the evening, so I'll be brief. With the vaccine rollout, and I know we talk about the plan quite a bit, and I think that people think that this is a hypothetical plan or just a discussed plan. This is actual written and submitted plan of action that we have that adheres to the tiering guidelines to the state. And it is all encompassing for employers. One of the things that we had the ability to do with emergency management in the state of Nevada is gather employer data number and identify all of those groups here that qualify under tier 1, so such as our home health groups, groups like Beehive, things of these natures, and we're going to go straight through that. As far as the date and the rollout of the vaccine, we are working with the state of Nevada to try to identify the date and the quantity of vaccines that are coming in. That is ever changing, so we're being flexible and keeping a positive attitude to roll this out to the community. And when that does, I know we've talked about lists and people on there. We've identified the employers, we've identified the quantity of people that fall into tier 1. And when we have the dates and are ready to open the pods, and we're going to have a few days notice, we're going to reach out to those groups and notify them. So that way the folks that fall into this that want to accept the vaccine are able to come into the pods. It should be a relatively efficient process. We are able to get people through, and it's not going to leave anybody left out. And it sounds like there was some concern earlier in the meeting that, maybe groups weren't going to be able to participate in this. If they're identified in those 1 through 10, and the focus really is on our healthcare workers and frontline healthcare providers, we're going to have the vaccine available to them, and they're going to be able to come to the pod and receive the vaccine. We're also even, working with Great Basin College as of the last couple of days for their nursing and EMT students that are in clinicals that have patient contact to make sure that we're taking care of those folks too. We have weekly meetings with the state of Nevada to continually evolve our plan for Humboldt County, and we were one of the earlier counties in the state to have a written plan submitted into state public health for this. So we do have a very efficient process there. It is going to cover everybody who needs to be covered that is in those tier 1s. We do have to adhere to those guidelines, because adhering to those guidelines is what allows us to get the vaccine into our county and be able to deliver it to those folks. It's 758 folks out of a county of a census of 16,200 some people. We're getting vaccine to almost 4% of the county just on our tier 1, and that's a really big step for a county. So I think that we're doing good. We are continuing to work with the state. We are continuing to identify the quantity of vaccine that is coming in, and Marsha Foreman and I from Public Health are consistently working together to make sure we can deliver that in the most effective manner possible.
So thank you, Sean. We appreciate you very much. And folks, if you're not aware, Captain Sean Wilkins with the Humboldt County Sheriff's Office is our local emergency manager. And he has just done a bang-up job. And I can tell you, because I've been there very many nights, late at night, early in the morning, and Sean's there, and he has just done yeoman's work, and we certainly appreciate it. Thank you very much. Dr. Stringham, is there any last words you'd like to say before we jump out?
No, I'd just like to say that I really appreciate everybody's attendance, and we're hoping that that everybody who attended can help to spread some of the messages that we've delivered to clear up some of the misunderstandings that any community members may have. I think the other thing I'd like to say is that the vaccination is a very welcome thing, and we're really excited about the possibilities and kind of the safety that this is going to give us. I'd like to reiterate the one thing that I was hoping somebody would have asked, but so I will answer kind of an unasked question. We've had almost 700 cases in our county over the last 9 months. This will really get your attention. 50% of those, half of those cases, have been during the last 2 weeks. And so I'd really like to emphasize to everybody how important it is. Even though we have a vaccination that's inbound, we've got some great technologies and some really good news on the horizon. It's still absolutely paramount that each one of us does the right things, because this virus is spreading very quickly, and we're already going into Christmas with far more cases than we really should have. It's my estimate that about 2% of the people you would come into contact with during an ordinary day will have this virus. And it's really critical. If a person is walking around without a mask in our community, and they're spending time with a number of people and socializing and pretending this doesn't exist, It's not that you could become infected. You probably will. So it's really critical at this point, with the number of cases we have, that everybody engage, that we all do the right things, and so that we can get this vaccination delivered to all the people who are going to get this, and we can get back on with our lives. So thanks so much for attending, everybody.
Thank you again, Dr. Stringham. And folks, pay attention to the, your different forms of social media, the county website, as well as we'll work with the radio stations as well. We plan on doing some more of these. And so we'll talk more about that as to how this went. And I hope you found it valuable. And I would also ask that you reach out to anybody that you know who wants to hear the recording. I know we've been here just about an hour and 40 minutes. And but I do recommend that if you want questions answered, that's a place to do it. We can do it via the recording. And as I said, the radio stations, are either simulcasting and or re-recording this. So there's lots of opportunities to rehear this again. Also, if you have any Spanish speaking friends, on Friday, I believe it's Friday at 7 o'clock, we're going to do this again, all in Spanish. And Dr. Stringham has promised me that he's going to speak complete Spanish the entire time. So I can't wait to hear that. But no, we will have a translator. And so we're very excited about that, to get the message to our Spanish speaking community. Again, thank you, everybody. Have a great night, and be safe out there. Have a good night.
Thank you, Dave and Charles.